side not yet reached. Somewhere I can switch on the video. I don't know when my network is clear or not. Thank you so much everyone for joining us for today's session. And as Rajalakshmi mentioned, we have a very important topic today. We have been hearing about management of various symptoms and many other issues in adults so far. And we most often, many settings tend to ignore children who needs palliative care, and it is very difficult, I must admit, to talk about palliative care in children with families as well as healthcare workers. And that is why today's session is very, very important, and we have the most apt faculty for today's session. I would like to introduce Dr. Hariprasad. Dr. Hariprasad has been working in pediatric palliative care for many, many years, and he has started a first pediatric palliative care outpatient clinic at the Tertiary Care Center, that is a government medical college, Trivandrum, in association with Pallium India. And we had hundreds and hundreds of children, mostly with non-cancer, that is non-malignant conditions. And he was always a strong teacher and support and guidance for all of us to take this pediatric palliative care forward. And he was very crucial in developing protocol for procedural pain in children, which is still widely accepted across the country. Thank you so much, Dr. Hariprasad, for being with us to today's session. We have another faculty, Dr. Meghan. Dr. Meghan is leading the pediatric palliative care in South Asia under the Two Worlds Cancer Collaborative. She's also the program director palliative care at Children's Hospital at Ontario, and she's a telemedicine consultant for MSF, and she's also a specialist in palliative care, specifically a pediatric hospice. She has an immense amount of work which has happened in Asian countries. She has a lot of Project ECHO programs and other collaboratives across various countries in South Asia. And she has numerous publications and a lot of honors in her name. Thank you, Meghan, for agreeing to be a part of today's session. Thank you so much. Over to you. Whoever is going first can go first.
Thank you very much. I think I'm supposed to go first. Is that right, Dr.
Yes,
Hari?
please.
Okay. Can I just have the permission to share my screen?
Yes, doctor, you have it.
Okay, thank you. Great. So really warm welcome to all today. I'm very happy to be with you. It's really nice to join you all. And I will give just an overview of like palliative care for children, a little bit more in general, and then Dr. Hariprasad will really complement this with experiences of how it's been done in the Indian context. So we're trying to make sure we don't overlap, but have really nice kind of content on both and all parts of the topic. So I'll talk about just like what is palliative care for children, when should we start palliative care for children, which children we can give palliative care for, and then a few tips about how to provide palliative care. So actually giving you some things that you can take away from today's session in terms of like changing your practice. I know that maybe you're not going to see lots of children, but if you do see them, how can you do some things that will be more helpful for them and their families? Very similar to adult palliative care, we focus on prevention and treatment of pain and other symptoms. We focus on psychosocial and spiritual concerns, just like you have learned from about palliative care in general. It's for children with serious or life-threatening conditions and their families. And I like to have this image here where it shows the little girl and her mother, just to remind us all that, like, you know, when a child is sick, it's the whole family that's affected. And so the palliative care has to support that whole family. And some key concepts that we really emphasize in children's palliative care is that it's not that they have to choose palliative care over something that might be curative, especially for cancer treatment. Sometimes it's very hard for the family to decide palliative or curative. Sometimes they want to try some chemotherapy and they still need palliative care. So we can give those two things together. And in fact, in some pediatric palliative care programs, we actually give palliative care from the time of diagnosis with the cancer for all the children, even though some we know for sure will be cured, but we know that they have better outcomes and better survival if we give good palliative care at the same time. And it's best started at the time of diagnosis, which I'm sure you've learned, and you've probably seen a slide like this before. where, at the beginning, at the time of diagnosis, most of the treatment is the light blue. It's the disease modifying treatment. And then over time, the palliative and supportive care can increase. And it might not be a straight line like this, how it increases, but over time, as the disease progresses, the patient and family might need more palliative care. There's more symptoms, there's more burden of symptoms. And then in that terminal phase, we call it end of life care. It's mainly focused on palliative care. And then after the patient's death, which you can see here on the right-hand side, then there's bereavement care. So this kind of shows how the palliative care can intersect with the potentially disease modifying treatment. And if we look at this image, this is a drawing from a mother who was kind of reflecting on her child who had cancer, the experiences they had. At first, she was told, oh, you need palliative care. And she was very worried, oh, I have to choose. But then she said, I realized actually it's one door that opens together and we give all the treatment that that child needs. So I like to show that picture just to remind us what we're thinking about. Why is palliative care needed for children? Sometimes we just think about adults because there's so many adults with serious illnesses and we forget about children. But there are estimated to be 31 million children globally who need palliative care each year. And in India, there's estimates have been done that there's about 34 per 10,000 children. So that equals 16 lakh children who need palliative care each year, including about 50,000 children with cancer. And all the children in the world who need palliative care, the vast majority are living in low and middle income countries. 98% of them are in low and middle income settings. A few other thoughts about how we do palliative care. One thing we try to avoid saying is there's nothing more that can be done. This just gives parents the feeling that we're giving up on their child. We also feel bad if we say this because we feel like, oh, as physicians and nurses, we failed. But we know there's always something that can be done. We can always do active symptom control, support the family, provide home-based care. There's lots of things we can do. And we've seen a lot of experience, and I'm seeing this experience from India. I've got a picture here of M&J Cancer Institute in Hyderabad, where I've done a lot of work with the team with Dr. Gayatri. And we found that really early integration of palliative and curative therapy was like a really big benefit for the patients. There was smoother transition to like a more end of life phase when that occurred. They had better pain routinely was screened and reported. So they identified children who had pain and they treated it more. And that led to decreased treatment abandonment because, parents would abandon treatment just because they felt like the child was suffering so much during the cancer treatment and they wouldn't come back. And then we also have minimized catastrophic health spending. So sometimes the families spend so much money on treatment, but it's maybe futile treatment. So helping them understand what's going to help and what's not going to help. And palliative care is really important for that. And we take this kind of integrated approach where sometimes we're giving at the time of diagnosis only palliative care because the child doesn't have an illness that's curable and they might progress to getting end of life care. Sometimes we give palliative treatment and curative therapy together. They get some supportive care as they go along. They may progress to end of life or they may be cured. So there's lots of different paths they can take. So this is just kind of to show you that idea that you don't have to know for sure this child is 100%, having an illness that they're going to die from. You can give palliative treatment. If the patient gets better, they get cured, great. You did a good job and they can go on to live well. So I've talked about what is palliative care. I've talked about when to give palliative care, about this idea of the early integration being so helpful. And now let's look at the different types of children that need palliative care. And I want to highlight this part because just to emphasize that it's probably different from adults, okay? So if you mainly care for adults, you're going to maybe not know about all these diseases that I mentioned, and that's okay. There's lots of rare genetic metabolic diseases in children, and even me, I can't keep track of all of them. They're discovering new ones and identifying them because they have so much more genetic testing now. But it's just to kind of know the patterns and the ideas of the types of illnesses that children might have. So some conditions where children might need palliative care. Children living with a progressive condition where they have a progressive deterioration in their health. Or in their ability to do the things they need to do. So these are kind of neurodegenerative conditions, sometimes we call them. And I'll talk more about them in the coming slides. Children with a life-threatening condition, for example, something like cancer, which is life-threatening. It might be curable, but it's not always cured, right? And then many times there are children with pain or other symptoms, and we have to help address those, even if the child may not die from their illness, but they're still having a lot of suffering, right? So we have to think about quality of life, which we've learned about from all of the palliative care training that you've done. So in pediatrics, they divide it into 4 different groups of children who need palliative care. And I'm going to go over each of them. So I'm not going to read them here. I'm going to go one by one through the 4 groups. And the 4 groups are helpful because the way the children progress in their illness is different for most of the groups. So category 1 is an illness that is life-threatening, but curative treatment is available, but it might not work, it might fail. So for example, cancer, right? Like many of those children, it's a life-threatening disease to have cancer. There's a potentially curative treatment, but it's not always going to work. Other things in this category is like congenital or acquired heart disease. So sometimes children can get treatment for heart disease, like they get a surgery, but doesn't always work. Serious infections like meningitis, cerebral malaria, multi-drug resistant TB, organ failures, blood diseases, and prematurity. So lots of different diseases fit into this category. But what you might see is that this is thinking about a child with like a leukemia, say. The child gets diagnosed over here and their condition, you know, if this is down at the bottom here is when their condition is very poor and they're actually dead. And this is like when they're at 100% health. That when they get diagnosed, they're not at 100%, or maybe their health is like 60% of what it was before. They actually usually get sicker because they get a lot of chemotherapy, they get a lot of symptoms from that. It makes their immune system so weak. Obviously, it helps them because it potentially cures them, but they may get worse. Then they go into remission from their cancer potentially. Their health is quite good and stable for a period of time, but maybe they have a relapse. Their cancer comes back, and so then their health gets much, much worse. They may get more cancer treatment. They might get a bit better from that, stable for a little bit, but then maybe they have another relapse or a complication, and then they proceed to end of life and they pass away, they die. So you can see how this can be confusing because, you know, for the family, they get told certain thing, but the child gets worse. Then they get better, everyone gets very hopeful, but then they get much worse again. So there's kind of like this up and down, this yo-yo that the family goes through. Category 2 is conditions where there's a long period of treatment which aims to prolong life, but premature death is anticipated. So the condition is not curable. There's nothing you can do that would definitively cure that condition. Some examples might be HIV/AIDS, although somehow it may be moving out of being even in this category because it's almost becoming just a chronic disease. Cystic fibrosis, muscular dystrophies, spinal muscular atrophy, which is a rare type of disease where the muscles become very weak, chronic or severe respiratory failure, and severe immunodeficiencies. So lots of different diseases, and you're starting to, you know, I said you're going to start to see these diseases with very strange names that you maybe have never heard of, or you saw them once in medical college or nursing college. But just to know that these diseases do not have a cure. So you can prolong life, but you're not going to be able to fix the underlying thing. So sometimes what these patients look like is that they're quite stable for a while. This might be before they're even diagnosed, they might be stable. Then they have a little dip in their health, which is maybe when they get diagnosed. They might have a small pneumonia or something that brings them into hospital, but they get better from that. But then they have another dip and they get quite sick. Maybe they have a worse pneumonia because their muscles are very weak. They can't cough, they can't breathe very well. But then they come back up from that second dip. They get better again, but for maybe a shorter period of time, hard to know. Then they have another dip down where they get quite sick. They're back in the hospital with some illness, infection, and then they get better. And you can see this pattern repeats quite a number of times before the child dies. The thing that makes this hard is, again, that yo-yo for the parents. Like every time the child comes sick and it gets in the hospital, the parents are told, oh, he might die, he's very sick, but then the child gets better. So it's hard for the parents to hear this over and over. He might die, because every time he gets better. And so they're thinking, well, these doctors don't know anything. He always gets better from this. But one time he does die, right? They get weaker and weaker and over time progressively. So it's just kind of living with that uncertainty is hard for the family. So then we have category 3. So these are progressive conditions where there aren't any curative treatment options. So there's not really anything you can do for these kids to make that straight line, this part here, longer. Okay, they're going to have a stable period, but depends on the disease, it might be very short. And, in some conditions, you can push this straight line for longer with certain supports or treatments, but in category 3, you really can't do that. And here is where we get into all the rare things. So you don't need to know the names of these, just know these are the types of diseases. So the chromosomal disorders like trisomy 13 and 18, metabolic diseases, I've given you an example, it's called mucopolysaccharidosis, neurodegenerative conditions like Rett syndrome and adrenal leukodystrophy. These are rare. You might not know what exactly the child has, but you might see on MRI that their brain is clearly very abnormal. Sometimes these children have this kind of trajectory, not always, but sometimes another trajectory they can have is that they may come in, they may get diagnosed, they may get a bit better because, you might be able to optimize a little bit, like maybe they're being overfed and they're choking and coughing and aspirating. And if you don't do that, they get a bit better. They have some period of stability, and then they tend to have kind of just a very sort of stepwise downwards progression. The condition degenerates and they kind of progress along. They're a little bit like adult patients with neurodegenerative conditions like ALS or dementia even. And this line is very straight, but sometimes there's a bit of up and down, a bit of that up and down that we were talking about here. You might not get a totally straight line. You can have an up and down as well. And then category 4 is children with a severe disability that leads to vulnerability to complications, and then that causes the premature death. So this is mainly children with severe cerebral palsy, moderate to severe cerebral palsy, which is a brain injury or brain illness where they have motor problems. Their motor cortex has been damaged, usually by prematurity or by a birth-related neurological injury, birth asphyxia. So these children, it's not the cerebral palsy that really causes them to die, it's the complications of it, right? They get chronic recurrent respiratory infections and respiratory, then they get like chronic respiratory illness, they have chronic lung disease, and eventually they tend to pass away from something like that. You can see a very similar picture if a child has a severe brain injury, like an older child who has a traumatic brain injury from a motor vehicle accident or a fall or something, a hypoxic brain injury like from a drowning or a severe infection. And then there's some rare brain malformations that children are born with, that cause a similar picture. And these are the names of them. And you wouldn't know except for if you do an MRI, these children will have small heads. And they might have this kind of trajectory where they go down a little bit, they stabilize for a while, then they go down again, stabilize, down again. They tend not to get better than they were. They tend to just stepwise go down. Again, these are kind of idealized curves, but just to give you some ideas of the trajectories that children might have. Now, if we look around the whole world at the types of illnesses that children have that need palliative care, you can see that cancer is not that big. It's here, and I don't know if you can see the numbers very well, but just 5.7% of children globally who need palliative care have cancer. So we have other diseases, we have cardiovascular disease, HIV/AIDS at 10%, meningitis 12%, malnutrition 14%, neonatal conditions and congenital anomalies are much higher. So these are the main groups of children that actually die if you look around the world. They may not be the main groups of children you see because it depends. Do they die very early before they come into a palliative care program? That can happen too. Like a lot of babies are dying in neonatal intensive care or around the time of birth, and they may not come to palliative care just because there's not programs designed for them. Our experience in Canada, just to give you a little bit of a sense of what a palliative care program in Canada sees, 25% of the children, their primary issue is a CNS condition, like a neurodegenerative condition or some brain injury or cerebral palsy. 18% is chromosomal conditions. 17% is neuromuscular conditions like Duchenne muscular dystrophy. 14% is cancer. 14% is metabolic diseases. And just under 10% is cardiac disease and 3% other. So it's a wide variety, I guess, is what to take away. If you're at a hospital, this is a pediatric hospital-based experience. If you're in a community setting or a home-based program, tends to be higher numbers of children with CNS conditions. That's our experience. Just to say, now let's move on to our very last objective for the last 5 minutes of my talk, and I'll talk about what do we do? How can we do good palliative care for children? So a few things is one thing we can do is have good teamwork. So in one of our pediatric palliative care programs in Bangladesh, this is what our team looks like, who's caring for the patients at home. We have a pediatrician, it could be another type of physician, doesn't have to be a pediatrician, but someone who knows about children's palliative care, a nurse. We have community workers who are called palliative care assistants. We have community volunteers, we have a physiotherapist, we have a coordinator. And at the center of the team, part of that team is the patient and their family. The things we assess the patients on, so like if we think about when we do our first assessment, how do we assess them? It's their physical issues, so like their pain, their other symptoms, emotional things, not just psychological problems, but like how do they feel about the illness? How does the family feel? How do the siblings, the brothers and sisters feel? How are they coping with it? Feelings of sadness, anxiety, etc. Social issues, like how is the family coping? School, community, friends, how are they all involved and what's their impact? Spiritual concerns. And then lastly, we put in this extra one on the bottom, which is trajectory. So that's thinking about what curve is this child on, of those curves I showed you, what's going to happen to them in the future, what's kind of their, like, when are we thinking end of life soon, or how long are they going to live, and what's it going to be like as they go forward in life. So I'll tell you about 2 more key practices that we use that I think are key things you can take away today that you can maybe bring to your own clinical practice. So the first is just understanding what does the illness mean from the child and family's perspective, which is very important for all of us. What do we know about parents when their child is seriously ill? They want recognition from us as their doctors and nurses that they know their child best. They want to feel like they are good parents, that they're doing everything a good parent would do. They want clear and honest information from us. They want the information communicated in a sensitive and caring way. They want to trust us. They want to know that they can trust us and call us and ask them. And if the child's going to die, they do want that preparation for death from us. They want us to actually tell them. They don't like it if we hide that from them, if we think the patient is dying. For children, they want reassurance that they will be looked after, loved, never alone. They want clear, simple, honest information that is at their age, and they want to be able to play. And play is so important for children, to express their emotions, to escape from the stress of being in this illness situation, helps them have a place where they can make choices about what happens and they can succeed, and helps them better understand their life experiences. They can like play it out and cope and understand the experience. We see that in children. That's why we have playrooms. That's why we have play ladies and play therapists. These are all really important for children in hospitals who are sick. And then the second and the last practice is just to give families the information they need. You know how I said they actually tell us when we do interviews and studies of them after their child has died, like they don't like it if they can kind of tell the doctor knew the child was dying, but didn't tell them, was uncomfortable or didn't want to tell them. They don't like that. They actually do want us to be honest with them. So I would say that the big thing to take away here is that families want clear and honest information, including prognostic information. We can ask them first, how much information do you want? And that doesn't take away hope. That gives them a way to frame their hope and know what their hope should be or could be. And then we often use this I wish, worry, wonder framework. I wish that things were different, but I worry that your daughter is very sick. I wonder if we should make a plan for how she can be cared for at home to make sure she doesn't have pain or other symptoms. I just gave that as an example, but this idea of using an I wish, I worry, I wonder statements, it helps parents accept and hear the information because we're saying it like I put it on myself as the clinician. This is what I worry about. This is what I wish for. And they can accept or not accept that from us, but it helps soften it a bit. So in summary, a few things if you're interested for future training. We do have a fellowship program, which is a 1-year program to become a pediatric palliative care specialist. This is mainly for pediatricians, okay, but just to tell you it's out there. That's the program, and it's with the Hyderabad Center for Palliative Care. And then these resources are good for everybody. This is the ICPCN, which is the International Children's Palliative Care Network. They have free online courses. They're asynchronous. They're like on a website and you sign in, you get a free account and you can complete them, and you get certificates from the University of South Wales for completing all the modules. There's 9 modules. And then this is a very good book I highly recommend, and these slides can be shared and this link can be shared around. It's a symptom control manual. It's an ebook where it tells you for each symptom how to manage it in children and all the medication doses. So I will sum up there. We talked about what is palliative care. I really love this phrase. We cannot add days to their life, but we can add life to their remaining days. But we talked about what is palliative care, how it's active and total care, includes all the things that we know from adult palliative care about physical, social, emotional, and psychological and spiritual care. We focus on best quality of life and providing holistic care for the child and family. We talked about which children need palliative care and all those different types of diseases, and gave you some idea of the different trajectories of the life-threatening and life-limiting conditions. And then we talked about how palliative care can help with pain and symptom management, can help with giving patients and families information that they need and communicating with them, and that I Wish, Worry, Wonder framework being so helpful. So I'll stop there. I think I'm at the end of my time. Thank you very much.
Thank you so much, Megan, for covering very comprehensively, given the limited time that we have given. But we think that this should be something like a food for thought, so that people who are interested or people who see kids in their setting can think of getting into more intense training maybe in the future. Thank you so much for sharing your experience in that. Over to you, Dr. Hariprasad. We'll take the questions together in the end, probably so that both of you can take a. Thank you so much.
Okay.
Dr. Hariprasad, yes.
Thank you. Thank you, Dr. Sridhar, for the fine introduction, and thank you, Dr. Mangan, for that fantastic, elaborate discussion on the global aspects of palliative care. I hope I am audible.
Yes, sir, you are.
Okay, so I just once I shall share my slides. Okay, is it clear?
Yes, sir. In presentation view, it would be good.
Okay. Okay, right. Okay. So, so having heard the global aspects of palliative care as well as the basic principles of palliative care, so I shall just discuss on pediatric palliative or Indian perspective as well as my personal experience, because basically I'm a pediatrician, and I'll be just discussing with you my personal experience, how I am managing children with the chronic disease as alone. Okay. So, so just we'll discuss some a few case scenarios. So this is a 13-year-old girl, adolescent, who came to us in OP with a severe respiratory distress, and her investigation showed a complex heart disease for which a supportive surgery was done in the newborn period. But since the family did not have any money, they didn't have any further follow-up, and the child was district given address, and the child was always at home and not able to go to the school, and the lesion was inoperable. So you can see the twins. The second of the team present the global development delay with intractable seizures, and practically the child was in the hospital for nearly 6 months. The child is about 7 months, and in spite of the hospitalization in the severe spasticity, the family was attending the tertiary care hospital for daily physiotherapy, and the treating doctor told them that a new drug will be arriving in the market soon, and that is going to cure all his problems. So this child, again an adolescent, diagnosed with acute lymphatic leukemia. They had treatment at Orissa, that is Bhubaneswar, on the Institute of Medical Science, and finally they were told that the child will not make it, and they were doing supportive therapy. And one of the family friend told them that if they come to Kerala, there are a lot of other alternative forms of medicine. And the next morning they landed in Kerala with the hope of recovery. And finally, child was admitted under our care in Ernakulam Medical College with a severe pain, with a score out of 10 and out of 10, and with significant bleeds all over the body. And this news came a few days back in our daily, which shows that the father murdered his son, who is having disability. The son was burned to death. So what does all this indicate? So all these case scenarios indicate the high burden of children needing or suffering from chronic disability and diseases. And ICP's International Children's Palliative Care Network has estimated that about 6 million children need palliative care in India. I'm sure, but I think it is very, very, very lower estimate. But however, we know that we don't have a disease-specific registry, and we really don't know what's the true burden. So I just looked up our own data at Trivandrum Medical a few years back. We showed that about 4.5% of children getting admitted in the ward, as well as about 1/3 of children getting admitted in the ICU needs palliative care. So I think this is a huge data, and this will be the same data if you take any hospital setting. And as Dr. Megan said, and the prevalence will be very high if we take the community statistics. So what are the issues? So I think a child with a chronic disease is suffering from various physical symptoms. You name a symptom, they have it. They suffer from various neurological symptoms like seizures, hypertonia, intellectual disability, bowel and bladder incontinence, vision abnormality, hearing abnormality, abnormal movements, etc. They are prone to have aspirations. They are prone to have oxygen dependence, and finally they may die out of respiratory failure and cardiac causes leading on to dyspnea, exertion, fatigue, all the features of cardiac failure. They have bowel incontinence, bladder abnormalities, feeding difficulties. So practically speaking, when a child is having chronic disability diseases, all the systems are affected. He is completely physically dependent, and the quality of life, not only of the child, but of the family as a whole, is significantly compromised. So generally, we fail miserably to look at the psychological issues. So there are a lot of psychological issues in the children per se. They are anxious, they are depressed, and some of them have suicidal thoughts, and they always have a fear of death. And another major chunk who are affected is the caregivers, and almost all the caregivers, especially the mothers, are depressed, they're anxious, and they have an insecure feeling, and they always have a significant worry about the future. So again, we looked up the psychological issues and the caregiver, and they told us that almost all of 100% had a personal distress. And even though they were with the child throughout the day and night in the hospital, the information given to them or shared to them by the health workers was totally inadequate. They didn't have any leisure time, and they were socially empowered. They failed to attend any social gathering, whether it's a marriage or a reception or anything. And probably they were always worrying about the unpredictability of illness, and they knew that the child can become worse at any moment. And it is at this time they go for divine interventions, and they go for or hopes for new breakthroughs. And probably the most important single question that is worrying them, and they will come and ask you, is what will happen to my child if I am not there? I think this is the most important single question we have to answer as a palliative care doctor. Again, probably the most important another group of children who are totally neglected in this family is the siblings. They are having poor social school performance, poor self-esteem. They are socially isolated almost always. Again, we had a study among the siblings, and they told us that they were not at all hugged or kissed by the parents. They didn't have any quality time with the mother, and they were less often called any for environments. And even though they wanted to understand about the illness of the siblings, they were not given any information. And at some point of time, they prayed to God that they wish to belong to a family without an ill child. So this shows the agony and the psychological distress the sibling is having. What other issues? The financial issues. Almost all of them are having significant financial problems. The caregiver or the breadwinner cannot go for work because of multiple hospital visits, frequent hospitalizations, and many of the time the father has to be present along with the child, and there's a lot of changes in the family dynamics. And we just looked at their out-of-pocket expenditure, and it was showed that about 80% of the income of the family was spent for the child with a disability. So we must understand that our social security system, even though we say that the treatment is given free of cost in all government hospitals, this is the reality. About 80% of the income were spent for the child. And you must understand that this data is from a tertiary care center under government setup, where we say that all the treatment is free of cost. What are the social issues? Yes, there are inter-family conflicts. And our own data showed that about 1/5 of the parents or the father just abandoned the family after knowing that his child is having a chronic debilitating illness. So slowly, initially there will be family support from the relatives, but slowly they move away. And finally, there is poor extended family support. There are significant financial problems, and they are totally isolated in the family, in the society as a whole. When such a child is taken to a local government hospital, private hospital, what is going to happen? Generally, they are small hospitals. Sometimes only the OP services will be there, and they will not get the proper treatment. Sometimes the doctor will not be available because many of the time we have only half-day OPs, whether it's a morning or evening times. And as soon as the doctor or the health worker sees a child with a chronic debilitating illness with a large discharge data and all, they will refer the child immediately to the nearest higher center. And many of the, even if the treatment is given and practically the appropriate care, they fail to provide the appropriate care. So that means when there's a child with a chronic debilitating illness, especially in rural areas, they have to take the child all the way to a tertiary care center, which may be 50 or 100 kilometers away from their house. So practically speaking, when there is a child with a chronic debilitating illness, they have got significant disability, they have got multiple comorbid factors, their lifespan is limited, at the same time that goes for years, and they're completely physically dependent. And when such a child is taken to a even a multi-specialty hospital, tertiary care hospital, what is going to happen? There are a lot of barriers. All of them, almost all of them provide a disease-oriented treatment. There is significant patient overload. That means we spend the same amount of time for a child with an upper respiratory infection as well as for a child with a chronic debilitating illness. We have got all the specialties, the cardiology, neurology, nephrology, GIT, etc. But everyone is functioning at their own modalities, at their own sites, and everyday OP will not be there. And even if we admit the child, we provide the treatment as long as the child is in the hospital. But one fine morning, we just discharge the child without any providing any home treatment, and we fail miserably to provide psychological or social support. So in this scenario, what is the definition of health? So actually, World Health Organization defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So that means that as a health worker, as a doctor, generally in India, we fail miserably to provide appropriate management of health for children with chronic debilitating diseases. So what is the answer? I think palliative care is the answer for this. So what are the, so haven't discussed the problems. So as palliative care physicians, let us look at the needs of these children and their families. Yes, the most important aspect is to improve the quality of their life, that improve the quality of life of the child, of the sibling, as well as the family members. Where to manage the symptom complex of children, we already said, almost all the systems are affected. We have to support the child and the family, the siblings, as well as the family, that is psychological, social, and financial and spiritual support. Yes, so they need a clinician or they need a physician who will meet their complex needs. We have to focus on high quality primary care. And generally, I think as far as children are concerned, the common source of infection is dental caries. And I think as palliative care doctors, we should focus on preventive care and please take care of the dental caries. And it is our duty to give immunization for all to all these children, including the optional vaccines, including the yearly influenza vaccine, because the common source of infection, one is dental caries and second is the seasonal flu, and that will lead on to secondary bacterial infection. And we had to ensure a continuous take of care as soon as the child is discharged from the hospital. And as a palliative care physician, we must have a stable relationship between the treating doctor at the clinics or at the center and at the healthcare team. And always, as Dr. Megan said, always address the pain of the child. So we should help them by managing all the symptoms. We should help them to take a strong decision, and the shared decision. It's a shared decision. That means we have to discuss all the pros and cons with the family, and we must help them to have a strong decision. And we must always help them to have access to urgent care. And as far as children are concerned, especially in India, we generally in government hospital setup, we take care of them only up to 12 years. And once they are just about 12 years, we refer them to the medicine department. And in some private hospital, they look after them to 18 years. And after 18 years, we refer them to physicians. So as a palliative doctor, it is our primary duty to facilitate this transfer, a smooth transition from pediatric care into an adult care. Yes, we must support the nutritional aspects. And rehabilitation periods is very, very important, because in our own experience, we can do a lot by implementing the various rehabilitation measures, where you respect their culture and the spiritual aspects. And we, as Dr. Megan said, finally they will die. And it is as a palliative physician's primary our duty to provide them a peaceful terminal phase, and we should ensure them a good death, and we should never abandon them after death, and we should continue to support them through proper bereavement programs. So, having discussed the problems and needs, so what is the reality? So this is the reality. You know, India is the most populous country in the world, with nearly 150 crores of population, and our children population, that 0 to 18 years, comes to more than 50. And if you extrapolate the data that's available from Western data, I'm sure that at least 6 crores of children in India will be suffering from chronic debilitating diseases, and more than 6 crores of children need palliative care in India. And it is a very complex country with more than 2,000 ethnic groups, with more than 29 accepted languages, and there's a wide difference of social, financial, cultural, and education parameters from the north to the south, from the east to the west. And look at the left, and this is the reality. You look at the number of pediatric palliative care centers we provide, just a few, and that too is concentrated in the cities like the Tata Hospital Bombay, the Vijayawada at Bombay, the All India Institute of Medical Science in New Delhi, the Cipla Group at Pune, the Hyderabad team, the NMJ Institute under Dr. Gayatri, the Manipal team, and the Palliative team at Trivandrum, and the Institute of Palliative Medicine and Carrier. So practically, these are less than 10. So, and you look at the reality, that is more than 6 crores of children needing palliative care across India, and there are nearly 10 centers who are able to provide a proper palliative care in India. So this is the huge difference between the facility and the reality in India. So what is our duty? So having trained in palliative care, I think this is our duty. We should help them to meet their needs through proper communication, by giving meaningful hopes and by helping them to take shared decisions. And always never fail to address the concept of total pain whenever we deal with children and their families. And you know that it is physical, psychological, social, and spiritual. And whatever we said, then there are a lot of pain-free programs going on across India. But I think there are a lot of specifications. But I think the take-home message is, as far as pain or palliative care is concerned, I think, as Gandhi said, I think we must be the change. So unless we change, unless we step in forward to provide appropriate care, probably the child will never get any support. And this is a goal-directed care, that is from the goals of cure to goal to prolong the life with a good quality, and finally to provide end-of-life care and to continue the support with bereavement program. And I think this is already discussed. So we have to identify the various problems. We have to assess the various problems. We should have a detailed plan, that is advanced care planning, goals of care, treatment plans, and we should always link with the resources, and we should always prepare them for emergencies, and we should manage the symptom, the psychological, the social, the spiritual needs, and we should always refer to for assistance whenever needed. So having discussed the various issues, their needs, let me share with my own experience what I did where I am working. And you must understand that I am working in tertiary care center without any support or we don't have a team as well, and I am working as a team. So this is the child, 13-year-old girl with a complex heart disease came to me at the age of 13 years with a significant respiratory distress. And because of financial crisis, they didn't have any follow-up. So child had, we evaluated the child. So child had a suprasusceptible pulmonary pressure. That means it was inoperable. So the only offering that was a treatment is there's no hope of cure. We can only support the child with the supportive therapy. And child was dizzy even at rest. And child was class 1 second floor, and here the greatest ambition was to go to the school almost at least half 50% of the days. And the story continues. The father deserted the family after knowing that the child is having incurable illness, and mother was going for daily wages, but she had to be with the daughter, so she also lost her daily job. And there was no extended family support, and they didn't have a house of their own. And the grandmother of the child was also with them. And but as usual, the family members are all depressed. So what did we do? Yes, child was put on oxygen, and child was also put on a sildenafil to reduce the pulmonary pressure. And as having exposed in palliative care, you know the role of morphine. So drug of choice of dyspnea in palliative care setting is morphine. So we started the child on morphine. We also so the child symptoms improved significantly with the morphine, home oxygen and sildenafil. But we were planning to send the child home, but we didn't have any fund to raise to have an oxygen concentrator. So I challenged our interns, and within 48 hours they raised 40,000 rupees, and they bought an oxygen concentrator. And you can see the interns with the child and the mother having the oxygen concentrator. So within 48 hours, our interns raised the money. They bought an oxygen concentrator, sent back the child to their home. We also gave a letter to the principal of the school requesting her to shift the class to the ground floor. And you know that oxygen concentrator has to work for 24 hours. So we gave a letter to the electricity board, and who made the electrical supply free of cost. And there's another program going on here, life program, through which we can also give a letter to the government, and through which they also got a house of their own within 6 months. So practically speaking, within 2 weeks, child was symptom free. Child, her class was shifted to the ground floor. Child would go to the school at least up to the forenoon, and they could get a house of their own within 6 months. And so the symptoms were getting well controlled. Child could sleep comfortably. Child could go to the school, and they could own a house, and the mother could go for work also. So I think there's a lot of compassion in the next generation. So it is primary responsibility to encourage them and to inspire them. And this child, a diagnosis of West syndrome was made, and the child was admitted in a very, very morbid state. So we thought of providing end-of-life care to the child. And so we had a shared decision after proper communication. We shifted the child out of ICU. We sedated the child with the midazolam, and morphine was given for respiratory distress. And child was also given subcutaneous fluid. But to our joy, the child recovered completely, and the child is still there even at the end of 2 years. And we have ended an advanced care plan, and we have already written an advanced care plan with including withdrawal of withdrawal from ventilator once the child comes back in morbid state. And we also plan for end of life care. And so you can see the child at the end of 2 years. So actually we are waiting for his 3rd birthday to be celebrated in the next summer. So actually this is a miracle. And so I think if you practice palliative care appropriately, you can add life to their days. And actually, you can include, you can also prolong their life. And so this child, I told you, this is a child with acute lymphoid leukemia coming all the way from Orissa to Kerala. So we started on morphine, and we had to give almost 100 milligram of morphine per day, plus adjuvants and via and paxil transfusion. The child was stabilized, but child wanted to go back to Orissa. So once the stabilization the child, we encouraged the family to book the train. We gave our contact number to the phone, and we kept contact with the family over the phone for the 2 days. And a detailed letter was given to AIMS Bhubaneswar. So child reached AIMS Bhubaneswar, where child was given a proper care, and child had a very good death at AIMS Bhubaneswar. So to conclude, I think practically palliative care is nothing but clinical medicine with empathy. So I think all the health workers can practice palliative care, and please consider the possibility of total pain. And I think we should be empowered in using morphine, and we should be masters in managing symptoms. And as far as whenever we deal with children, Dr. Mangan was saying the 4 various conditions, and a lot of genetic conditions are there. So as far as possible, a genetic confirmation will be possible, will be desirable, because we can advise genetic counseling, and we can advise regarding expansion of the family as also. So active listening is very important. We should learn the art of communication. We must always be true to them, and we should always give them only meaningful hopes. And even in our setup, we can go for withholding and withdrawal from ventilator. And we should always help them to have a shared decision, and we should shoulder the responsibility. And I think we should respect the patients and the caregivers. So as Bengan rightly said, let us add quality, let us add life to their days and not days to their life. So palliative care is need of the hour. I think all health workers should have an exposure to principles of palliative care. And I think all palliative care physicians or all palliative health workers should have an exposure to pediatric palliative care also. And all major hospitals should have palliative clinic. And I think we should be able to provide palliative care wherever we are, whether we are working in hospital, clinic, or community, even at home. And just one word about end of life care. So this is the quality of care, quality of death in as country ways. We are, I think, lacking behind almost all the countries. Even we find countries like Uganda. So actually, I think all of you will be knowing this young lady, Aruna Shanbag. She was brutally assaulted, and she was in a moribund state for nearly 42 years, and at KGM Hospital, Bombay, and all the staff nurses took care of her for nearly 42 years. And a bill was filed in the Supreme Court asking for end of life care for her. And it was in 2010, the Supreme Court came out with this great order: when treatment is futile, withdrawing life support of humane and unnecessary. But they place a lot of criteria for that. And again, thanks to the whole team of Palliative here and Palliative India and Rajagopal sir, they went after this. And on 24th January 2023, they came out with the revised order saying that advanced care directive made in front of notary and gazette officer is only needed to provide end of life care, and there is no need of countersign by the magistrate. And so we can just constitute 2 committees constituted in the hospital where the patient is admitted, and we can take a decision regarding withdrawal from life support, and no need of district collector also to be involved. I think this is a landmark judgment. I think with this policy in situ, we are more empowered to provide, including all palliative care, including end of life care in India. So India is a complex country. A lot of differences between the rural and the urban, the poor and the rich, the south and the north, west and east. So I think primary, as a primary health worker, as a palliative care doctor, as a palliative health worker, it is primary our duty to provide palliative care wherever we are. So let me conclude quoting this great man, Uttishtada, Jagrada, Prapyavara, Bodhada. That means arise, awake, and let us not stop until the goal is reached. So thank you all. I think we have just begun. The road is a long way, but there is always light and at the end of the tunnel. So thank you all for the patience.
Thank you so much, Dr. Hariprasad. Yes, we have all seen this or learned a lot from the pediatric palliative care unit that he was running. Thank you so much for sharing your experience. We'll take up a few questions, and this is a group of participants who most of them are working in rural parts of the country, where mostly the primary care itself is not accessible. So I'm sure they might be seeing a lot of children with needs, palliative care needs. So we'll wait for a few minutes to get some questions from the participants. Participants, you can either unmute yourself or you can type it in the chat so that we can discuss that.
Do you have any questions in the chat box?
Till now, there is no question, but usually they'll take a few minutes
Right.
to type and come up with questions. How many of you, like just curious, how many of you among the participants do come across these kind of situations where, I mean, of course, you will be the primary treating physician. So would be interesting to hear from you, how many of you come across these kind of situations in your practice?
I think they can share or they can ask their doubts also, whether.
Yeah, there is one question already. What is the role of sildenafil? I think sildenafil in PhD. Yeah, how does it act?
The pulmonary vasodilator. So you know that once the right side of pressure, the pulmonary pressure becomes suprasystemic. That means above the systemic pressure, practically the lesion becomes inoperable. So then we can only provide a supportive therapy for the child, and the sildenafil is a pulmonary vasodilator. So that's how it acts.
There is another question: highest dose of morphine that can be given for children.
I think morphine has no higher limit, isn't it? Because our aim is to go, the role of morphine in palliative care is one is for respiratory distress and second is for pain. And as we know that, I think there is no ceiling dose for morphine. And we can slowly step up the dose of morphine, titrate the dose of morphine, and once the pain is controlled, we can titrate the dose of morphine. I think, yes, I think Mahan has said the 0.2 thromboin and titrate the effect. So I think practically speaking, there is no ceiling dose for morphine. I think
yeah, very true. I think the challenge would be to in our setting is to get that dose. So be friends with your pharmacist. They have certain techniques by which they can crush the tablet, divide it into small parts. So each part will be equivalent to what dose you have asked for. I mean, that will be one way, because the syrups are not literally available except in 1 or 2 settings. And pediatric preparations itself is not available. So when you need for a small baby, it will be challenging to get the desired dose. So it is not about morphine, it is about our system where we don't have opioids for children's need. That will be one challenge. I think the next question I would ask Meghan, what about your experience in giving awareness about pediatric palliative care across settings where they are unheard of? I mean, palliative care, talking about palliative care itself is still a challenge for all of us. So then you are talking about children who literally, it's very difficult to accept palliative care and children together.
Yeah, I mean, I think, you know, Dr. Hari presented really good. So something that helps if you're at a hospital or at a clinic is like looking at your patients who come in and like seeing if they need palliative care. Like Dr. Hari said, like this percentage of patients who got admitted to Trivandrum needed palliative care, like they had a serious illness or they had a chronic disease. And there are several studies out there published like that show this percentage of children who get admitted to a hospital need palliative care. Like it's very clear, you know, looking at children who die also can help. Sometimes telling a story of a patient is really helpful for building awareness and helping people see and saying this is how the patient can be helped, and more emphasize on here is how they're being helped by having palliative care, how it benefits, like a lot like what Dr. Hari was saying, the stories he was telling are really helpful.
And I will ask the same thing to Dr. Hariprasad, because there are hundreds of doctors in the same institution. But you were the one who took the lead and still supporting everything. So I know that it is, when you talk to 100 people, maybe you will get one Dr. Hariprasad or one Dr. Mekhan. But will be interesting to understand what made you think of integrating palliative care in your service, so that the audience, for them, it will be helpful to, I mean, where to hit the nail, maybe.
Okay, so thank you, Sridev, for that question. I think as I would like to quote Gandhi, because I think we have to show the change. So unless we demonstrate the changes in the children whom we are dealing, they won't be happy, or they will not believe it. That's a problem. Because when I started practicing palliative care about 15 years back in Trivandrum, so they will be knowing it. And we had a lot of challenges, and nobody was referring patients, and they were actually dead against implementing palliative care, even giving morphine to children. So, I didn't resist anyone. I just slowly sat in a room and started doing palliative care. And slowly they started seeing children. They said that nothing can be done. They saw children slowly who were completely bedridden, getting symptoms controlled. The mother more happier, and actually the quality of life for the child and the of the family improved significantly, and even the quality of life improved, and even in the duration of life also became prolonged. And we had one child who was completely with mom's encephalitis, was completely bedridden, and everyone wrote off the child. But at the end of 3 years, he became absolutely normal, and he came back to Trivandrum about 4 or 5 years back. At that time, he was a plus 2 student, and now he is a computer engineer. So I think this such miracles can happen. And once you demonstrate such changes to your colleagues, I think definitely they will start slowly believing in you. I think that is the only way out. And at the same time, you start sensitization sessions across India for pediatricians, for health workers, for staff nurses, for MBBS, for other doctors. And when you sensitize them, one fellow or 2 fellows in among a few hundreds will be charged, and they will jump out and they will start practicing palliative care wherever they are. So I think advocacy is the most important way in general, and leading from the front, wherever you are working, is the way out for each person, for all of us. I think that is a way out for establishing palliative care in India, especially children's palliative care.
And I think that what Dr. Hari said about doing a good service and like really showing that you give a good benefit to the patients, then that really encourages and motivates your colleagues to send the patients to you once they see, oh, this is not just like he's not doing anything for them. Like they see, oh, these families are so happy that they got such good palliative care, that then they send you more patients. So it's usually pretty self-fulfilling once it gets going.
And I would like to have one more point, because generally they even before coming to palliative, I even thought that palliative care just means giving morphine and providing that to the child. So only after landing in the field of palliative care, I knew that we can do a lot of service. So I think we should tell them that palliative care is not giving morphine, but there's a huge science behind it. So once we preach the science behind this palliative care, I think our medical fraternity will have more belief in that.
Very true. And Dr. Manish has asked that question, and Dr. Manish, yes, it is high time that so whenever you get a chance to talk about introduction to palliative care to a group, always include one story of a child. That's what I personally do. That's all we can do, right? I mean, we talk about adult stories, adult patient stories, how we have changed, how we did the pain management, etc. So I try to put one story of a child, so that, okay, it is not just about people who are adults or probably elderly, but it is also about children. So in every session, include one point that conveys that children are also included, and deaths and chronic life limiting illnesses also happens to children. That's something very difficult for everyone to hear or accept. and we think that children are children, they don't die. So we have to talk about it. We ourselves are not comfortable to talk about it. So that's one thing that you can do. And if you get one pediatrician on board, I mean, he can help you as an advocate, because when they talk, the peers, I mean, their colleagues tend to, okay, why this guy is doing palliative care? Let's know something more about it. So that might be helpful. Any other questions from the participants? We'll wait for a minute if there are any questions.
Are they seeing children in their palliative care practice?
Yes, that's what I want to know. Participants, please tell us whether you see children in your practice. Both of them have gone through a lot of illnesses that can, I mean, I'm sure you all work in rural areas and you will be dealing with a lot of issues that they have mentioned. It will be interesting to hear from you. Do you actually see these kind of children?
Yes, ma'am. Hi, ma'am. I'm Dr. Manish. Actually, in our hospital in Thakurpukur, we have a pediatric unit, pediatric cancer patients, but we usually don't get a call for a pediatric palliative care. We have adult patients, we have adult wards and pediatric wards separate. And what I faced during my last, I've joined since last 8 months as a palliative care consultant. I've tried to convince the hematologists, the medical oncologists, they're giving me patients, surgical oncologists, referring some few patients. But pediatricians, I have asked them a bit about this, and they're very not very comfortable with the palliative care and the morphine, particularly for children. And even if we do have only 10 milligrams, but not the 5 milligram tablets available, but for the children, even with the divisions and all, they are not comfortable yet. I have tried to convince it once or twice, but would like to make a presentation in CME based on this, because most of the other departments are to some extent not fully convinced, but pediatric people are not yet at all convinced from now on, well, till now actually. So I wish to make them aware about the opportunities available in my hospital here in Thakurpukur. That's all I can say then.
Thank you so much.
Dr.
Yes,
Manish, have you got morphine stock in your hospital?
Yeah, yes, sir. We have a morphine stock in our hospital. We are an RMI, and so every 3 months or 4 months, when the stock is in the near the end, we send the indent to the particular department concerned, and we get that morphine. So we have a supply of morphine, and but only the adult patients are receiving the benefits still now. And I've not yet convinced the pediatric patients to get them, because they're not even the nursing staff in pediatric wards, they are not even trained for that particular division of morphine and how to break them and give 5 milligram or 2.5 milligram of into children. So I have the lowest age I have treated or given morphine was around 14 years of age. So
Okay.
there I gave a 5 milligram of morphine then in that particular. He was a very thin built, around 20-25 kg person. I can say adolescent.
I think
So,
the way out is sensitive, because pediatricians are always afraid of morphine. As soon as they hear the word morphine, they run away. I think
yes,
that is
absolutely.
a common scenario across India. So I think the best way is to have a CME or a
Yeah, exactly.
workshop.
I'm planning only. Yes.
Yeah. And one expert should come there and talk on morphine alone, especially in the palliative
Yeah.
care. I think that will,
Yes,
and
yes.
I think that is the way out for them.
Yeah, correct, sir. Absolutely.
Yeah, I
Yes.
think sometimes they're like neurosurgeons. Pediatricians only listen to other pediatricians. Like they don't believe adult physicians. They think they don't know about children. But so sometimes if you can find a pediatrician who is already doing some palliative care, like someone from within India who you can invite to speak, and you get them to come
Yes.
down and make a big deal about it, and they're very famous, blah, blah, blah. And then they say the
Yeah.
exact same things you would say, but the pediatricians will listen a bit better at first, but you kind of be part of that so that then you can continue it, and they can tell their experiences. You know, like we have, Wadia has a pediatric palliative care team, and they're using morphine in premature babies. You know, I use morphine in premature babies, telling them it's safe, it's effective, that's really, you know,
Yeah, that will
if
have
they
a
hear it.
more impactful. Yeah, that will
Yeah.
be more impactful, right? Yeah, yeah. I will definitely keep it in mind, ma'am. Thank you. Yeah.
And I'm sure they can, the Pallium team can connect you with some pediatricians who would be willing to give a
Actively
talk for
practice,
you.
yeah.
Within India, there's a
Hmm.
solid group of maybe 20 people who, you know, somebody could come and give a
Okay.
talk. I'm not totally sure
I
where
will.
you're located.
Yeah.
I didn't catch the exact
I
location.
am in Kolkata, ma'am. In Kolkata, in eastern part of India.
Yeah.
Eastern
Okay.
part.
So close to Bangladesh too. So yeah.
Yeah,
Yeah.
yeah. You can say yes.
There's who's close. Okay. Yeah. We can look at somebody, try and find you somebody.
Yeah, I will contact Pallium India for the same because I have kept it in mind within the next 1 or 2 months, want to do a CAB on based on this only. Yeah, thank you.
There is another question about morphine and respiratory depression in children.
So if the morphine is given at the proper dose, just like in adults, it shouldn't cause respiratory depression. So we have the dosing, we follow the WHO guidelines for the dosing for the morphine per kg. 0.2 to 0.3 is the oral dosing to start with in children above like 1 year of age. That should not cause respiratory depression. No, that's a pain relieving dose. And then for small babies, like premature babies and under 1 year old, then I usually give lower doses to start. So 0.1 per kilo oral, and give it every 6 hourly and just observe and titrate. So then you should be fine. Yeah, you won't get into trouble if you use those doses. And you know, if the patient's still
I
having
think it's
pain, you
same
can
as in
always
adults.
titrate up. Yeah, exactly same
It is
philosophy
about
as in
your
adults.
assessment and whether you're choosing the right patient, and give it in a small titrated doses and attention to details whenever you start morphine. I think everything applies to children. I mean, same thing, the children also feel pain. So
Yeah, that's a really good point, Sridevi, that, you know, thinking about it, like children have a right to a pain-free life. And so sometimes we talk about children's rights and their right to have pain treatment, and we shouldn't prevent them from that right to be comfortable. And even babies who can't speak, who can't tell us in the same way, like they suffer a lot, those NICU babies when they're in the hospital, because nobody hears their cry and listens to them. And I always feel like there's such a group that's so under treated because they can't yell at us. Like if an adult was intubated in an ICU and not getting good pain control, they would just like, you know, really make noise until somebody did something. But the babies are so small and nobody listens to them.
I was remembering when I was working in another hospital, we started morphine for a child with osteogenesis imperfecta. The child was in severe pain, but the pediatrician asked me, like, children will cry when they are hungry, when they want to pee, when they want to poop, and when they are in pain. So how can you tell that the child is crying because of pain? It can be because the baby is hungry. So you can't just start morphine right away. So that was one question he asked. Obviously, we could. I asked. There was a nurse who was taking care of the baby, and the nurse was 100% sure that the baby is in pain. So what else do you want to? But these are the questions that you might encounter because children cry all the time. So how can you tell that it is because of pain? They can't tell you they are in pain. I think there are another question. What
Yes,
about the
other
side
question.
effect of nausea and constipation?
So I think any handwriting morphine should prescribe an antiemetic which that acts on the chemoreceptor trigger zone, like metoclopramide, and also they should be given a stimulant laxative like bisacodyl. And generally, we can stop the antiemetic after a few days if there's no vomiting. But as long as the child is on morphine, that continues the stimulant laxative, the bisacodyl. So I think that is answer. Okay, so always give an antiemetic and a laxative whenever the child is on morphine.
you so much. I think there are no more questions in the chat. If there are more, we'll send it across to the experts. Thank you so much, both of you, for being with us for today's session. Thank you so much for sharing your experience with the participants. We'll be seeing again for another sessions like this, both of you. Thank you so much. Thank you so much, all the participants, for being with us and interacting.